It's my great pleasure to introduce the dream team up here when we're talking about behaviour, learning and cognition. Dr. Charles Albright from Nationwide, Dr. Aaron Hauptman, again backing up 2 sessions in a row from the Kennedy Krieger, Dr. Andrea Miele from the Children's Hospital Colorado, and Dr. Jessica Scherr from Nationwide. Please join me in welcoming the team. And they're each going to present a short presentation to you guys, and then we'll open up for a Q&A again. Guys, before we start, would you mind just introducing yourselves a little bit more and sort of what your sort of expertise and areas of interest are within your own specialties as well? And then you can kick it off.
Good morning. Okay, good. Thank you for that kind introduction. I'm so happy to be here to be able to speak to you all. Again, I'm Andrea Miele, a pediatric neuropsychologist at Children's Hospital Colorado. And so my primary role is to kind of track cognition over time in treated and untreated kiddos. I'm the neuropsychologist for our Batten and kind of neuromanagement clinic. And I've been working that clinic came into existence in 2020, so I've been involved since then.
Hi, I'm Jessica Scherr. I'm a psychologist at Nationwide Children's Hospital. Kind of my areas of specialty are in neurodevelopmental disabilities like autism, neurodegenerative diseases like Batten disease. I'm part of Dr. Emily's clinic and team, where kind of my role on that team is doing assessments and looking at cognition and development over time, and then also providing behavioral supports and how do we advocate for increasing learning and skill development and maintenance.
And I'm Chaz Albright. I'm another psychologist from Nationwide Children's Hospital, and my training and job are very similar to Jesse's, so our jobs are very similar. I'm going to focus my time talking about behavior and some of the ways that we can think about behavior with our Batten's kids. And I wanted to just put a plug in here that we really want this talk to be a lot about having a conversation, so we're going to try and keep the talking as brief as people who like to talk can. And then do a lot of question answering and conversation with you all, because these are all really tricky situations that we want to kind of problem solve together. And you guys have so much expertise in working with schools and thinking about learning and thinking about behavior that we think that'll be really helpful throughout. So think of your questions, think of comments. We won't claim to have every answer, but we'd love to have the conversation. You got it.
Hello again, I'm Aaron Hauptman. I'm at Kennedy Krieger in Baltimore. I'm a pediatric and adult neuropsychiatrist. I work with kids with a lot of different diagnoses, a lot of different brain-based conditions that impact emotion, behavior, and cognition, and I have a particular interest in working with kids and their families around progressive neurological conditions like Batten disease. So it's a really great pleasure to be here and get to speak with you all.
Okay, now is this one working? Yes. Okay, so let's get this started. Use the computer here. Okay, so I'm just going to let's just launch into talk about how we look at cognition in individuals with Batten disease. I am going to disclose this, that our Batten clinic does have some funding from the Rare Sisters Batten Disease Foundation, and then I have some funding from some other groups that are not related to this. So just to kind of set the stage, something that we know that we're looking for is important to follow in individuals with Batten disease are cognitive changes and cognitive losses. We know that timing of symptom onset will vary by type and that the order of symptom progression can also change. But this is a picture just to kind of show from a earlier paper from another very prominent neuropsychologist in this field, Dr. Heather Adams, who's been working with these kids for a very long time. This paper is from 2007 that just shows the areas of difficulty in some verbal and working memory skills. So we know the stages that we're looking for this, and we want to make sure we're measuring this and capturing the changes correctly. So there's lots of different ways to study cognition. I kind of have this list up here. I bolded neuropsych evaluation because that's what I do, but there's also, it might be called a developmental assessment, a psychological or psychoeducational assessment if the school does that, or a research assessment where, all of these things could be measured. So then I sort of break it down after that into 2 layers, into one kind of a performance-based part where the child or the individual actually has to do some things. Paper and pencil-based tasks, could be computerized tasks. We have one tool that's kind of more toy-based that the individual has to show us what they can do. And then there's also the other part that's really important is the parent report. And that includes an interview and questionnaires. And so really, to me, we need all kind of both of those, or all 3 of those pieces to have a full, really good picture about your child or the individual with Batten disease. So we want all of those together. I think I'm kind of belaboring this point because we don't want to overemphasize sort of one aspect. We want to look at everything all together for the clearest picture. So, okay, so you do an evaluation. So the first evaluation, what happens is we're going to compare kind of those results to other individuals that same age and sometimes that same gender. So you're comparing, your individual to peers. So great, it's a baseline, it's a starting point, but then to me what becomes even more important are the following evaluations, because then we can still compare your child to their peers, but more importantly, we can compare your child to themselves, and so we can track their individual trajectory, which is what we really care about the most. And so, I sort of already said this. So, we get the norms or we get the raw scores, and then in order to compare your child to their peers, we use what are called norms. And so this is published by the test companies on thousands of individuals, kind of without a medical history on how they have performed on answering the same questions. So this is sort of how we compare your child to their peers. We compare using these things called norms. The norms are set on this bell curve, which shows the normal distribution. We won't kind of get into the weeds on this, but this is how, the performance of raw scores gets kind of transformed into what scores are kind of in the average range, which I have here, and then the various ranges kind of above and below. But as we are talking about measuring change over time, how do we know, change is meaningful, and what are some sources of information that tell us about change? So again, one place to start are these things called standard scores, so from the norms. So this is just a snapshot of some scores from a child that I saw who has, you can see kind of 2 evaluations there, 2018 evaluation and then 2019 evaluation, so 2 evals a year apart. And we see that this verbal comprehension index, which is part of an IQ measure that we give, kind of went down from 95 to 84 over the course of a year. But so we lost, about 10 points. Like, what does that mean? Is that meaningful? We also see the auditory working memory index kind of went down from 63 to 56. But again, what does that tell us? How might that kind of manifest over time? So the next place we can look to try to understand this are the individual indexes that go into these domains. So I kind of have them in boxes. So the blue box goes into the VCI, and then the gold box goes into the working memory index. So this is kind of the next place we can look, and we can say, okay, well, on the similarities subtest, it looks like the score went from 10 to 7. So that does seem kind of like a bigger loss. But vocabulary, 8 to 7, just kind of down 1 scaled score point. And then on the information subtest, the score is actually the same. So it's kind of giving us a clue that perhaps the increased difficulty in the verbal domain was because of whatever happened on this kind of similarities test. So it tells us a little bit of a more detailed place kind of to look. Now, on the working memory index task, I definitely clicked that. We just have losses of kind of 1 scaled score point, 3 down to 2, 4 down to 3. So it doesn't seem like a lot of movement to me, yet we almost have the same amount of gap in the 2018 score of 63 down to 56. So I'm just kind of illustrating this to talk about kind of a lot of the numbers that you might be presented with, and how it's really important to not kind of overemphasize one score over another, or to just like really try to look at them in depth to know what's going on. So I kind of have another example here where we see limited movement and verbal comprehension from 2018 to 2019, but then we had a little bit of a loss from 2019 to 2020. And we can see this larger movement in the scaled scores here. 5 went up to 11, but then kind of went down to 9. But again, what does this mean? I have one more kind of example here on a memory task. But I think you guys are kind of understanding at this point, what I have from standard scores just leaves me with some questions. I kind of have some evidence of movement. Some things went up, some things went down, but how much in the losses do we actually care about? And so one of the ways that we can then take these norm scores to try to understand them are to calculate these kind of fancy indices, this thing called reliable change index and this standardized regression-based change. So there's fancy things that we can kind of do with the standard scores, but I actually think what's a better use of our time is to investigate the raw scores. So one of the take-homes from what I'm talking about today, if there's like one take-home, is anytime you have a neuropsych eval or a school eval or any sort of evaluation, please ask that provider to provide raw scores. Because if you come to see someone else, if you come to see me, if you come to see any of these other fine folks at the table nodding along, it's very hard for us to understand what's going on if we just have the norm scores. We need to see the raw scores to really understand what's going on. And that's kind of what I'm trying to illustrate here. It's just that, so we have the scaled scores in the boxes, right? So the scaled scores are the norm scores, the comparison of your child to their peers. And so we have 6 to 5, 5 to 4, and then 7 to 9 in the RAML here. This is a memory task. So we look at the scaled score of 6 kind of going down to 5, but in fact, the raw score is actually the same. So your child didn't actually do any worse over time. It's just that their peers were able to do a little bit better over the course of kind of whatever that gap in time was. So I think that's important for families to know that, okay, the score went down, but actually your child's individual performance did not change. So to me, that's a very different conversation that I'm having versus, okay, memory, was worse. That's an inaccurate statement when we start to actually uncover and look at the raw scores. Kind of the same thing for the verbal learning delay here. We have kind of 5 kind of going down to 4, but actually this child did better. They had no points when they first saw me, but then they had 1 point later, so that's actually, again, a little bit better, even though we have a loss in a norm score. Similarly here, the 7 kind of going up to 9, so that sounds good. And then kind of what does that look like? How many points more kind of did they achieve? And so 26 up to 31, so 5 more answers correct. So it's just how, we have to be very careful when we look at kind of how these scores move in time to get the most accurate picture. And then I have this kind of down here as well. So on a word reading task, a score of 60 went up to 68 on the standard score. So great, we definitely had improvement. Although I could see someone writing that this improvement was just sort of, expected, because 60 is relatively close to 68 when we're talking about movement and standard scores. But for a parent, this child was able to either name a letter or read up to like 16 more things, whether it was letters or words. So to me, that's pretty big. That's a lot of words that we were, or letters that we were able to read or identify. So really the raw score just tells us a lot. And hopefully these examples kind of make sense. So I have more here, kind of similar stuff, where on this spelling example, we have a loss of 78 down to 70 on the standard score, but the raw score is the same. So all that means is just that compared to their peers, we would have expected that the child could spell some more words, but I think all of us might be pretty happy that we still have our 5. So just the picture and kind of what to work on really changes once you uncover the kind of etiology of the scores. This math problem solving increase, a standard score of 56 up to 82, like seems big, seems great. That's a lot of movement. And then we can quantify kind of how many more problems they were able to solve. We already kind of talked about the WISC, so I won't go into that. So hopefully this makes sense in how the standard scores, don't tell us a full picture. They sort of set the stage, but then we need to do more investigation underneath. Sorry. Okay. So these are if tests that your child was able to complete were in age. So sometimes we want to give a measure because we've seen a child a serial number of times and they maybe have aged out of the measure, but we still want to see how they're doing individually on there. And so for a test like that, if we're administering it out of age, we don't have normative data to go on, we only have raw scores. And I know I've talked a lot about how raw scores are really important to me, but then if I only have raw scores, then I still feel like I need something else to help me explain what's happening for a change in raw scores. And so there's some other metrics, some measures that we have age equivalents, and so that can be helpful to look at, okay, this raw score kind of places your child around this age equivalent level, which can be kind of helpful to talk about in terms of behavioral challenges, putting them in the context of maybe where their age is. But the type of score that I'm actually the most excited to kind of collect more data on and work on are these things called growth scale values. And I want to just direct you again to, this is a paper that talks about the use of different scores literally in pediatric neurodegenerative disease. So it's not a paper only written about Batten, but Batten has a big part in it. This is also with Heather Adams and the group. And so they have this kind of table here that compares GSVs and these growth scale values scores that I'm talking about, kind of their utility across and compared to other types of scores. But hopefully this example will kind of elucidate why I feel like these scores are meaningful for me. So this is a picture of a report that I can get from the Vineland. Now, has everybody in the audience filled out a Vineland? Do we have nods? Sorry. Yeah, exactly. So this is exactly. Thank you for that. Yeah. Thank you for that layup. So yeah, my next statement was going to be, so I know that the Vineland is sort of, people probably have a love-hate relationship, maybe more hate relationship with it, but please understand, or please know that this tool really can tell us a lot. I know it's a big effort to fill out, and it's hard to fill out. You're faced with a lot of questions that are frustrating and could evoke a lot of hard feelings, but if we use this tool well, I really do think it helps describe your kids well, and it actually launches pretty well into ways that you can kind of tweak therapies and tweak things with your school. So anyway, what I'm talking about here, so we have some scores here. So the adaptive behavior composite is a score that we commonly talk about because it's kind of an overall. It's not an IQ score, but it kind of could be used to tell us kind of at what range your child is. Again, this is just like a standard score. So here we have about almost 2 years apart. We have this score of 80 where all the scores have really dropped. It looks pretty concerning when I look at this table. But then what these GSV scores can tell us is actually about, again, the individual movement of your child's scores over time. And so these ones that are gray, well, actually all of the scores on here, you can see that they all go up. So 47 goes up to 59, 35 goes up to 49, so they all are increasing. So that tells me right away that, okay, the standard scores went down, big deal. All that means is that the gap between your child and their peers has gotten wider. Okay, but this child has actually made gains across almost all domains over time. So the ones that are gray are the ones that are kind of statistically significant. And so to me, this is huge because this means that we don't really, not that we don't care about this level, but what's happening for this child over time is that they've been working really hard and they've actually made gains, and all of the work that this family has been doing to get their kiddo to therapies and the school team, and I really think we see the evidence of that work here. And this, I think, is the more important picture. So please think about this next time you fill out the Vineland, that this really will lead to probably better understanding of your child if you have a provider who will look at these scores. So this is why kind of repeat testing, I think, is really important. It sets the stage to kind of really understand your child's trajectory and being able to kind of tweak emphasis on certain therapies or not. I've had some families come to me who say, we are maxed out. Like we are trying to work on everything all of the time, and guess what? There are not enough hours in the day. Is there anything we can pull back on? And so then we can go to the data, and if I see, that language scores are maybe, stable or a little bit of improvements, maybe we pull back on that one for 6 months, or, talk to speech therapy. It can kind of give us an idea of at least some questions to ask about some changes that could be made. Understanding your child's cognitive profile can really set up school advice and other medical advice. And with that, I'm gonna turn it over to the next one. Thank you.
Hi, Jess again. So I will be talking about how to navigate educational supports and services in the school environment, specifically through an IEP. So 2 components of the Individuals with Disabilities Education Act. First is that any student with a disability is entitled to a free and an appropriate public education, meaning that that is individualized to their special or individualized needs. It allows them to make progress, and it's at no cost to the family. The second component is that these services and accommodations should be provided in the least restrictive environment. So as much time with other peers. I love hearing from families when I ask about school and they say they love all their friendships. They love the peers that they have there. They love that social interaction, and that's so important. So again, that least restrictive environment to have those supports and accommodations and services. So what is an IEP, or an individualized education program? So really this is a plan, and it's a legal plan that determines what sort of services, supports, and accommodations your child receives in that school setting. It starts with a school evaluation, so a lot about what Andrea was talking about with testing and scores. So direct testing of abilities, cognition, language, developmental skills, observations of the child in the school environment, parent and teacher reports, and then also a big one is also including outside evaluation. So if there has been a recent evaluation conducted or progress reports from outside therapies or from medical teams, that's so important to include in these school evaluations, because a lot of times those are coming from the experts that know Batten disease and know your child well, that you can incorporate into that school environment. So then after the evaluation, there is the IEP meeting, and this can be kind of intimidating because there's a lot of different people in that meeting: parents, teachers, intervention specialists, therapists, administration. And in that meeting, you go through the evaluation results, and you kind of develop this agreed plan to deliver services in the school environment. So some special considerations for educational services within Batten disease. Children with Batten disease have a different learning curve compared to other children with disabilities. So that means that we need to continuously monitor and adapt education. The IEP must be able to be modified at least once a year annually, with more frequent changes as needed. Goals should be appropriate and meaningful, and examples are looking at skill acquisition, so learning new skills, developing new skills, and more of a focus on daily living skills, adaptive functioning skills, than kind of academic tasks. And then there's this thought of proactive learning or proactive teaching, where we want to maximize as much as we can teach to delay further decline. So an example of this would be, well, a child still has communication, verbal language, words. Maybe we're working on that, but then we're also working on alternative ways to communicate for when there maybe is an eventual decline. So we're learning communication devices. while also promoting verbal language too. So that proactive learning. I also think goals should also focus on skill maintenance. Skill maintenance is a win, you know? If we have the same skills and we're not declining, that is awesome. And eventually slowing the progression of the disease through those goals and services. Other considerations, this is a rare disease and it's complex and it's individualized. And a lot of time, kind of where that student is in disease progression can look very differently. There is a high level of empowerment of the families. A lot of times families are experts of Batten disease and they have to teach their school teams about this disease and they have to advocate for their child. And also every school is so different in how they have resources that are available to help. And then there also is a high commitment of the school and healthcare providers to communicate together. One of the biggest barriers of appropriate services in rare disease is that lack of knowledge of educators and teachers. They don't know the course of the disease. So it's hard for them to kind of prepare and implement a plan if they don't know. This is why there's an increased need for communication and consultation across school, healthcare, home settings to teach and kind of learn together. So this is just an example of an IEP timeline. So it starts by requesting an IEP evaluation. And the critical thing here is to make that request in writing because as soon as school receives that, the clock starts ticking and they have 60 days to kind of make a decision to go through with an evaluation. Then they do that school evaluation and have that IEP meeting. It's important to kind of prepare in advance for that meeting. So kind of doing research about programs and different options. I think it's really helpful to talk to other parents too and get their opinions of what has been helpful for their child. Come up with your own individualized goals of what you would like school to work on. And then keeping in mind when you're in that big meeting with all those other professionals that you know your child best and to advocate. After that, they review, modify an IEP, and then you work on monitoring, or in some cases, disputing if you don't think it's appropriate. And then again, you should have that annual IEP meeting every year to update goals and see progress on goals. So some examples of what an IEP should include. So you should have current school performance across a variety of different areas. So academics, social skills, learning style, fine motor skills, mobility, behavioral challenges, communication, sensory considerations, vision, gross motor skills. IEP should have measurable goals. And again, it's critical for these goals to be both meaningful and measurable. And we should be monitoring these goals and keeping an eye on, are we accomplishing, are we making progress on these? In an IEP, you should also have the supports and services. So who, what, when, where, how often are these services being provided to your child? So examples are speech therapy, occupational therapy, things like that. These are some examples of common IEP services and supports that we see in Batten disease. So a big one is speech therapy. So working on expressive, receptive language. A big one is working on functional communication. So expressing needs, wants, and feelings appropriately. And this can be both verbally or non-verbally. So thinking about communication devices or alternative ways to communicate your needs, wants, and feelings. Can work on articulation, fluency, grammar, word finding, and also pragmatic language. So that's the social use of language. So conversation skills, turn taking, working on not interrupting, things like that. Another service that a lot of our kids get in school is occupational therapy, working on fine motor skills, skills of daily living, sensory sensitivities, physical therapy, vision, orientation, and mobility, behavioral supports, which Chaz will talk about in just a second, and also counseling services through school. So working on emotion and behavior regulation, social emotional functioning, and any psychological symptoms too, like anxiety, and learning coping skills. It's really important to monitor kind of progress. In your IEP, it should be stated on how often you will be updated on your child's progress in meeting goals. At least it should be an annual meeting, if not more, and you're always welcome to request a meeting at any time. I think there should be frequent check-ins with your school team and who's providing services to see kind of where we're having challenges, where things are going really well. Again, having everybody being on the same team and checking in often. So a reevaluation, any child with an IEP, they're required to have a reevaluation every 3 years. I would advocate annually, if not more. I'm just going to talk briefly about this because this is a nice segue to Chaz's talk, but also you can get behavioral supports in school. So if there are behavioral challenges, requesting to have a functional behavior analysis or assessment, FBA, to learn more about why these behaviors are happening at school, and more importantly, how can we modify and replace those behaviors with more appropriate skills. So that FBA, or functional behavior analysis, leads into a behavior intervention plan. I'm going to stop here.
All right, so I'm going to start talking a little bit about applied behavior analysis and behavioral therapy and behavioral ways of thinking about learning and managing behavior for our children with Batten's disease. And I wanted to highlight something as we got started, both in Andrea's talk and in Jesse's talk. We heard a lot about how we take these broad understandings of psychology, of school psychology, and we narrow them to this very specific instance. And I highlight that because all of you in here, everyone in here, in either being a family member, a loved one, a professional working with Batten's disease, this is where we live. You all, I'd imagine everyone in here had heard something about psychological testing and have faced IEPs one way or another. There are people who go to school for 4 years, 5 years, 6 years to understand these concepts. And you all in here understand them broadly, but then deconstruct them, which is what Andrea was doing with testing, to how it can mean something meaningful to that individual person in that really, really specific situation. And that's something that you all have done, and we have all done together, to help the children that we love. And that's something I think is really impressive in the way they can describe it, but also for everyone here in building those understandings. And that's why, one of the reasons why applied behavior analysis and behavioral learning can be so helpful. So there's a couple things I want to make sure we're all thinking about when we think about behavior analysis or applied behavior analysis. A lot of us, when we hear behavior, we're thinking bad behavior. That's not how behavior analysts think. Behavior analysts think as a behavior as anything that you do. That's why behavior analysts often seem like they think they can handle everything, which they can't. Because everything we do is a behavior, so it's all under our auspices. But the reason why that's important, because behavior analysis isn't just about reducing behaviors that are problems or concerns, which it definitely is, but it's also about increasing, maintaining, developing, and facilitating behaviors that we want to see. So behavior analysis is both a science, the way physics is a science, the way chemistry is a science of learning, as well as therapy that we do for individuals. This makes the language kind of confusing and messy sometimes. I don't know if people have engaged with that a little bit when we're saying, are we talking about this specific thing with ABA? Or people can sometimes be talking about multiple different things. But the biggest thing we want to think about is ways of using behavior, understanding how behavior works, and understanding how the environment affects behavior can help us affect and increase behaviors that we want to see more of, as well as reduce behaviors that we want to see less of. And as Jessie mentioned really nicely in her talk, a big piece for Batten's is trying to maintain behaviors that we're doing. We want to maintain what we have. We want to practice things. We want to keep doing what we're doing to the extent that we're able to. I use a lot of gym metaphors in talking about behavior because the things that we do, one of our mentors often said, we get better at what we do. The things that we keep doing, we're going to be more likely to keep doing. And when losing skills is a part of what's going to happen, we want to do as much as we can to push against that in what we do on a day-to-day basis. So a couple of principles that we're thinking of when we're thinking of behavioral analysis or ABA therapy is behaviors are often learned. This is another time you'll hear a lot of times in the general public say behaviors are always learned. They're not always learned, and we're in the situation where sometimes they aren't, because neurological conditions are situations where they're not always learned. Behaviors are also often a form of communication. What we do communicates what we want, what we need, what we're thinking of, what we're wanting to happen. So instead of thinking of behaviors as, why are you doing this? Why are you throwing that cup again? Thinking about what are we communicating? What do we need? It can help us problem solve how we can affect what's happening and think about what we would like to be happening. As I mentioned before, behaviors are things that we do. Not just things that are negative or hitting or kicking or biting, but also the things that we do like walking or running or jumping. A big part when you're thinking behaviorally, because I think a big part, I would argue, again, I'm biased, I was trained to think this way, but I think if we all learn to think a little more behaviorally, we'll be doing better on a day-to-day basis. But one of those tricky things is behaviors are something that can be observed, counted, or timed. You hear this a lot when we say, well, that child's being ornery. That child's being defiant. Can we count defiant? Can we count ornery? You know, we can think about it. We can do what we call operationalizing some of those things. But it's more effective when we say that if someone comes home and says they're being bad, that may mean something different to me than it does to Jesse, than it does to Andrea, than it does to anyone else. But if we say that child's been kicking other children at school, and yesterday they kicked someone 5 times, and today they only kicked someone 2 times, everyone's on the same page. No one's going to be able to say that they have a harder time with kicking today than they did yesterday because they're kicking less frequently. So it's important in behavior, when we're thinking behaviorally, to help think about what things that we can count, things that we can time, and things that are observable. Now, it doesn't mean that those other things aren't happening. That doesn't mean that their cognitive processes aren't happening. We're not trying to say those things aren't real, but they aren't. But when this part of our thinking, we're focusing on the parts that we can see. And this is, at the core, you know, there's a lot that goes into behavior analysis. There's a lot that goes into ABA therapy. But this here, we call a 3-term contingency, you may have seen before as the ABC model, is a way that we kind of break behavior down into its component parts, which are the antecedents of the behavior. Antecedents is just another funny word for trigger, or what comes immediately before the behavior itself, and the consequence, what comes immediately after the behavior. So there's a lot that goes into that we don't have time to talk about right now, but if we focus on the behavior that we see, what comes immediately before it, good or bad, and what comes immediately after it, good or bad, we can start to think about how we affect and change those things to affect and change those behaviors, either facilitate and make them happen more frequently, or try to reduce them by replacing them with more appropriate behaviors, teaching new behaviors, things like that. And so that is at its core what applied behavior analysis is. It's taking behaviors, breaking them down to their component parts, and teaching those parts explicitly to facilitate learning or reduce behavioral concerns by using systems of reinforcement. And so things that we can do in applied behavior analysis, like I said, when we're increasing or improving behaviors, we can use behavior analysis to help functional communication, as Jesse mentioned a little earlier, to help affect how and when we're communicating and using language as effectively as we can, whether that's verbal language or other nonverbal forms of communication. We can use behavior analysis to help manage attention, focus, and memory. Usually not so much globally. We're not going to do it in a situation where now you just have a better time doing attention altogether, or now our memory is better altogether. But what we can do is situationally, on certain tasks, help practice things in a way that's going to make it more effective to remember them and help us to maintain our attention when we need to. We can also use it to explicitly teach things like social skills or adaptive skills. And again, while I'm focusing on behaviors that we want to see more of, we also use behavior analysis to reduce behaviors that are causing us challenges. Tantrums, meltdowns, aggressive behaviors, self-injurious behaviors, and behaviors of non-compliance, where we need someone to do something, we need to get our child into the bathtub, and they're refusing. you gotta take a bath. It's not gonna go well if we don't take baths eventually. But how do we manage that situation in a way that we can hopefully over time make it easier and easier? So we know in Batten's disease and with the different variants, there are different issues that come up. We see increased aggression, we see increased irritability, anxiety, depression, restlessness, hyperactivity, and supporting activities of daily living. So a lot of our foundational activities, so sleep is something that we can use, behavioral thinking. Again, you talk to a lot more physicians here than behavior analysts at this conference, and that's important because the medical side of this is always going to be the first step. But there's things that we can do to help manage the environment, manage routines around things like sleep, around things like eating, that are going to help out increase at the front line where people are in the moment to help some of those things over time. And again, a lot of what we're trying to think of is about facilitating and maintaining functional skills where we can and when we can. So I will focus, just for the sake of time, on that top line there. One size does not fit all for ABA therapy. ABA therapy has become more and more common in the last 20 years, which is a good thing. As many of you know, it's often very common in treating autism symptoms. But one of the downsides that can happen with that is ABA was, at its very foundation, was about each individual person breaking down their behavior change and individually affecting those. And that should be very individualized to each person. But as more people do it, you have more templates. And as you have more templates, you have more one size fits all. And I would argue that's not good for any individual. But sometimes we can get away with it. Sometimes, you know, the t-shirt fits well enough that the next child can wear it as a hand-me-down, right? But that's not Batten's disease. You know, we're not in a situation, and this is, for better and worse, this is where parents, you guys are gonna have to be the advocates. Because we all in this room understand that, but not every provider will. And so inviting and encouraging people to think individually and to think critically is going to be important, and we can talk a lot more about it individually, but it's going to be important. And you know, most people don't avoid it because they don't want to, they're lazy. It's because it's hard and it's unclear. You know, people come to professionals' offices because they're supposed to have the answers. And I don't think I have all the answers for all the different behavior concerns that are, you know, that people are thinking of in this room. And so inviting people to help think critically and help try and figure things out, as opposed to be the person who just has the answer, I think also often helps us all out in these situations. So ABA therapy, if you're doing it, if you want to be doing it, you want to help everyone thinking that this is going to be an individualized process for each person. And so when we're doing ABA therapy, we want to be thinking about treatment goals. You'll see the ones here that we have. And I want to focus on the bottom part here, basing on the individual's age and current skill level. When you're doing ABA therapy, we're breaking down the areas, the skills that we're trying to think about increasing or maintaining, or we're thinking about the behaviors we're trying to decrease. This is where Andrea's testing becomes so important. Because now we have an idea of skills where a child may be emerging, where a child might not be able to do, where a child may be able to go in the future. But anyone can make a good plan. I make tons of them. I say, you know, I do a lot of tests. I say, hey, look, this is a great plan. Go for it. No great plan survives. That's why data collection and following the data and how things are going, how well the plan's working. When I talk to families about IEPs, what I always say is, what is the plan and how will I know it's working? Because we want to follow the data. If we're expecting this intervention to make the kicking happen less frequently, or we're expecting the intervention to help the child request food more with a card as opposed to, you know, hitting someone, we should be able to see those behaviors increasing or decreasing. So we should be able to very functionally see what we want to see if those things are successful. And we don't want to just keep doing it for the sake of ceremony if they're not making the changes that we want, or at least pushing against skills that may be regressing. So ABA therapy can be done in a number of different settings. It can be done in home. A lot of ABA therapy is done with therapists directly in home, where we can practice skills in that environment that's really helpful. They can also be done in centers. There's a number of schools that focus on organizing the school environment around ABA principles. There's also centers where you come in and do therapy more on the 1 hour a week, a couple times a week, things like that. But there's also parent training models. There's models that we focus on a lot at Nationwide Children's Hospital, where the goal is for us, as people who know something about ABA, to teach parents how to be behavioral thinkers and how to be behavioral problem solvers. There's a couple programs, one called Ruby, which one of our mentors helped to develop at Nationwide Children's Hospital and another number of other academic medical centers. There's also another program called Triple P that teaches these skills explicitly to give families the toolkits to kind of approach behaviors and think through them and affect them over time. How do we find ABA? It's always going to be helpful to first kind of check with your insurance company and see what's covered and have those conversations. Going and checking in with your pediatrician, looking for programs near you. There's a number of websites and things that we can have some resources for you all that you can help look up for ABA providers in your area. And then call them and kind of request an evaluation or intake. And what I often say is, the websites and things that we have that you can access to look for ABA providers, I like to balance that against your pediatricians, your teachers, your people in your area. Because there's a lot of great programs with terrible websites and terrible programs with great websites. You can only from a distance judge so much. So sometimes the people in your town and your areas are able to help you more on boots on the ground on what the kind of general opinion is of some of those programs. And then before we move on to talking about some psychiatry, I want to highlight that behavior analysis, ABA, is a specific type of therapy you may look for, but there are other types of therapy that we see here. We talked about parent training, behavior consultation. There's also what we call parent-child interaction therapy, traditional cognitive behavior therapy, and family therapy, thinking about the dynamics of a family, which all families are complicated, and families that are working with some of these significant medical conditions. There's always things that we want to be thinking about from those perspectives. None of these things are divorced from the principles of behavior analysis. The same way, just because we're not focusing on cognitive factors don't mean they don't exist when we're doing behavior analysis. So the B in cognitive behavioral therapy is behavior, just the way the B in ABA is behavior. And child interaction therapy is based on all the same principles. So a lot of this is working with your individual providers to find what's going to work best for you in your life and your situation, as well as with the resources in your area. And we're happy to help in the ways that we can conversationally. But these are things that we can take back to our individual providers and think about more in the future. So with that, we're going to pass it on to Aaron and talk a little bit more about psychiatry.
Wonderful. Well, first of all, it's just such a pleasure to be here and to be speaking with everyone. This is a really incredible conference, and it has just been a very moving experience over the past few days. So thank you all just for the pleasure of getting to be here. Can't hear? All right. I'll work on it. Thanks. We're going to try to leave a lot of time for questions, so I will be relatively brief. There's a couple takeaways that I want to make sure that we have from this portion of the talk. So neurological symptoms and psychiatric symptoms are a two-way street. When we have a condition like Batten disease where we don't have agents that treat the underlying neurological cause, and we know that many psychiatric, emotional, behavioral, and cognitive symptoms can be made worse by some of the neurological symptoms, but also can sometimes contribute to worsening those neurological symptoms as well. And we have treatments and interventions that we can try to use for those emotional, behavioral, cognitive, psychiatric symptoms. We really want to focus on changing the things that we have the power to change and addressing those. So for a condition like Batten disease, this becomes, at least as clinicians, for us, it feels like things that we can target and we can take very seriously. So we're going to talk mostly about that. These are my disclosures. None of these are relevant for today. Just like to include them. Okay. And this, in transferring the slides, got a little bit thrown off, so I apologize for the messiness here. But we often draw these artificial distinctions in brain-based diseases between what's neurological, what's psychiatric or behavioral, and all of these other terms. The brain is the brain, right? So a person can have depression for lots of different reasons. A person can have a genetic predisposition, a person can go through hard times, a person could have a neurological condition that's contributing, or a disease that in and of itself, one of that disease's symptoms, what that disease is doing to the brain, is causing symptoms of depression. So all of these can be the case for each of these symptoms for individuals with Batten disease, which is part of what makes it so difficult to tease apart. This came up in the question and answer session before, but will be a big focus for us today. So just very briefly, I'm going to talk a little bit more with a focus on CLN3, just because there's more like epidemiological and other data for that population, but all the principles that we're talking about here apply across the board. So symptoms differ, as everybody knows, in terms of onset, progression, and specific symptoms between the different CLN types. But just because we have comparisons, from individuals with one particular CLN type, the course can be dramatically different, right? So psychiatric symptoms are a sizable part of one person's experience. They may not be part of another's. 50 to 75% of individuals who have Batten disease, who have CLN3, have psychiatric symptoms. 25 to 50% don't. So let's just keep that in mind, because I know that the types of symptoms we're talking about can really vary so much, even while we have a couple of big categories that we're going to talk about. Just while we're talking about the epidemiology, just notable that it does seem like there's a greater burden of neuropsychiatric symptoms in girls who have CLN3 compared with boys. And while people have looked for relationship between the specifics of like specific genetic mutations within CLN3, there's not evidence that having one particular mutation versus another predisposes to different psychiatric symptoms. That can happen in certain conditions, but at least so far has not seemed to be the case. So with Batten disease, it is just crucial that we keep in mind how dynamic a condition this is, right? Someone's symptoms at 5 years old versus 10 versus 15 can be entirely different, which means that the kinds of behavioral, emotional, cognitive, and other psychiatric symptoms that we're looking at, we need to have a pretty dynamic understanding of what could be presenting when. So for example, many of the symptoms, and we'll talk about specific neuropsychiatric symptoms soon, but many of them can onset somewhere between 5 and 10 years old, peak during mid-adolescence, and for some subset of these symptoms, they will get better over time, on their own, regardless of what we're doing. Symptoms like agitation, aggression, irritability, for many people, those peak in teenage years and improve. But symptoms like anxiety and in particular apathy often can worsen over time. So this is a two-edged sword, but what it means is that the symptoms that were the most troubling, the most challenging when somebody was, say, 10 or 12 years old, and we may have had to treat them really aggressively, we may keep somebody on a medication for years after that, but we need to keep in mind that the course of those symptoms really could change over time, which means we need to constantly be addressing and readdressing which symptoms we're targeting, especially if we're using medications that potentially have more side effects, because they may have been necessary when someone was 12, but now that they're 17 or 18, we could really safely pull back on them. It's something that we just need to constantly be attending to. Okay. I have some busy and overcrowded slides here. I apologize. But some of these are just for people's reference and to try to give a general shape to the conversation. So apologies for being a little overwhelming here. When we talk about sort of the course of symptoms, in broad terms, often between 5 and, say, 9 years old, we can see behavioral changes, sleep disturbance, impulsivity, and shifts in personality. There's this question that came up earlier today and has come up at least a lot in my practice in the past few years of the relationship between underlying autism or neurodevelopmental conditions and Batten disease, And it's something that is just a complicated question that I don't think we have clear answers for. But we certainly have a number of families, many families, that have described neurodevelopmental symptoms way predating onset of visual symptoms. And I'm not sure what to say about it, other than to just put that out there and mention that we're aware of that and see that as a concern. Between 10 and 15 is when we see, the onset of some of the more challenging behaviors and symptoms for many people, psychotic symptoms like hallucinations and delusions. That's something that we see in the medical literature a lot. Honestly, psychosis like that is not something we see as commonly as I think it is talked about. But rigidity, obsessive behavior, I think, which sometimes can overlap a little bit in what we'll describe as psychosis, are things that so many of our families really struggle with. I could call it sort of obsessive compulsive symptoms, but that makes it sound a little bit too much like typical obsessive compulsive disorder. There are some features of that, but for many people it's that rigidity and the intense desire for things to be a particular way, even if those are not realistic or feasible. And then irritability, fear, agitation, and aggression. As people get a little bit older, many of those symptoms will calm down, but some of those anxiety symptoms may get worse over time. And for many people, the apathy, so the disinterest, difficulty with motivation, lower energy, those symptoms can increase, which sometimes can be more challenging, sometimes can be less challenging. It depends on what somebody's experience has been so far. This is just to give you a little bit of a sense of some numbers, and some of these numbers range really enormously based on the study. But as I said, about 3/4 of folks with CLN3, and this is specific to CLN3, I'm sorry, develop behavioral symptoms of some form. Apathy is common in more than half. Sleep disorders, by some measures, can be very common. Aggression, obsessive compulsive symptoms, irritability, repetitive behaviors, hallucinations and delusions less so, and depression in some. So we touched on this a little bit earlier. Diagnosis can make a huge difference and is meaningless at the same time. So many people with Batten disease can have psychiatric symptoms, but may not meet full criteria for a DSM-5 diagnosis of a psychiatric disorder. As somebody who's most interested in somebody feeling better and improving their quality of life, I don't care that much if somebody meets criteria for major depression or if they just are depressed. But that can make a difference in some contexts. So first, this can impact insurance coverage, which is a huge problem. It can impact IEPs and educational planning, right? If you don't have a diagnosis of autism in your chart, it can be very difficult to get school to pay for ABA or other behavioral interventions. Other support services or entitlements, the diagnoses are everything. And I think often we are, on the diagnostic end, clinicians can be nervous to give someone a diagnosis, like ADHD, if we know that the cause is this brain-based disorder, right? We're used to diagnosing ADHD in people who don't have another diagnosis, or maybe something like autism that is more common and straightforward. And so it involves, I think, just a careful conversation with your clinicians about, well, why isn't autism on his treatment plan or on his diagnosis list? Why isn't ADHD there? And talking about that. I've had situations where people have not had really important medications covered because I hadn't put a diagnosis in their chart or because they didn't quite meet criteria. It's a challenging issue, but I think is just mostly the opening to the conversation. Okay, what are some other reasons why we care? Well, when I prescribe somebody who has when I prescribe a 40-year-old with no other symptoms or diseases, an antidepressant for depression, I've got a good sense statistically of how different medications or treatments will affect them. And I could give you those numbers. And those medications are studied in those populations. But when we're talking about using, let's say, a common medication like Prozac on somebody who's experiencing depression in the context of Batten disease, I have no idea. The data's not there. So I could be using the medication in order to address those symptoms, But I can't tell you how well it's going to work. I can't tell you if it's going to address those symptoms successfully. So I can use clinical knowledge, we can use guidelines where we've got them, but it's something that has to be done really carefully, particularly because the side effect profiles can be different. Folks with Batten disease can have a lot of kind of idiosyncratic side effects to these medications. And we're often talking about kids, as has been part of the discussion all day, who are on a lot of different medicines which interact. This isn't a reason for us not to try these things, but it's a reason to just not be surprised if it goes differently. It may go better than we expect. I've had people respond remarkably well to small doses of a medicine that I was surprised was effective. And I've also had people not respond at all to a medication that I was sure was going to be effective for their symptoms. So we have to take that all with a grain of salt. Just some things to think about. We have to be really careful with certain categories of side effects. Antipsychotic medications can be really helpful for people with certain symptoms in Batten disease, but they carry a lot of risks and side effects, and we have to be very careful with them. People with Batten disease are also at higher risk for side effects like serotonin syndrome or extrapyramidal side effects, and we can talk about that during the Q&A if people would like to. But that's mostly to say we just have to be particularly careful with these medications. Not that we shouldn't use them, and I think we probably underutilize them for many people because understandably it can be frightening to enter into this world of trying these medications, but they can have some very positive benefits. Whenever we can, and this got brought up during the Q&A a little bit, we try to dovetail and overlap medications. There are some anti-seizure medications that can treat 3 or 4 different indications, or there are medications used for ADHD which can be great for sleep, or vice versa, excuse me. So whenever possible, we try to work together as a team and really target as many symptoms as possible. There are a lot of comorbidities that people with Batten disease experience, either directly from the condition or as a result of, say, issues with mobility that come up, issues with feeding and whatnot. All of these things can independently cause psychiatric symptoms. If you don't have Batten disease and you've got epilepsy, your risk of depression is 50% as a person in the population with epilepsy, right? So a lot of the conditions that go along with Batten disease also carry their own risks. So we need to really address that. If you can't fully manage somebody's epilepsy, that's fine. But if somebody's actively seizing and we're not really targeting carefully treatments to maximize their seizure control, it's hard to then address behavioral issues because honestly those can be made so much worse by neurological comorbidities. Excuse me. Related to that, constipation, I would say I've had more people present to me for like agitation or a new diagnosis of psychosis or irritability or whatnot because of constipation or dental pain. We really need to address these medical comorbidities. This is a sign I've been talking too much today. Okay, so there's like a small literature for specific medications for people with Batten disease, but it's limited. We can talk about that. I'm going to end on this slide here, which is terrifying, don't worry. But this could just be a little bit of a helpful heuristic for people to just keep in mind. And so I wanted it there if people wanted to take pictures or take a look at it later. But these are just some potential options, including non-medication options and potential medical causes to look for symptoms that are pretty common in individuals with Batten disease. We can talk about the medication side of that during the Q&A, but I think it can also be helpful just to see there are a lot of options for us to try to treat some of the behavioral, emotional, and cognitive symptoms that are going along. So I hope that brings some hope to our approach where we cannot treat the underlying condition, but we can really, try to carefully address some of these comorbidities that can really, truly improve somebody's quality of life. Okay. All right, thank you.
Okay, thank you all so much. We've got about 15 minutes or 20 minutes even if we want to take so long for the questions. So if you have a question, please come up to the microphone in front and then you can just hover around if you want to sort of form a casual queue if there are more than one question at a time. Would anyone like to be brave enough to kick off? And here we go. Excellent.
So the Vineland is not written for people with visual impairment. So like when I do it for my kids, I can think like, so one of the questions might be, are they aware of visual cues that someone might not want them to participate in a conversation? Well, no, they're not. But I think cognitively, they would be. So what are your recommendations of how to approach the Vineland in light of that very significant challenge?
Yes, that is a great question. Thank you for that. So I think that my answer is if we want to use the Vineland, if we want to interpret the scores that we get from the Vineland, we have to fill it out as the questions are written, which you might feel like it is going to underestimate your child's abilities, which I think I would hope that the clinician that you're working with might acknowledge that. But I think it, from a perspective, if we're going to try to track change, it might be too hard to track it reliably if you were to like fill out those questions, for example, like if is, you know, kind of tweaking it kind of for your kiddo. So I think this is, you know, the other side of that coin where we try to use the measures that we have to the best of their ability, but we acknowledge that there are going to be some limitations. I mean, the purpose of the Vineland is just to quantify a level of independence. And so we know if we have vision loss, we're going to need more support. So that's, in my mind, if you could separate those two for yourself, that the purpose of that is just to talk about how much help your kiddo needs. And we know they need more help because of the vision change, but that it's not necessarily indicative of their cognitive level. Like my hope is that that's why we do multiple things and we don't just do the Vineland. Does that make sense? There's another questionnaire that I administer that I often do have families kind of modify. It's a behavioral questionnaire, but there are verbal items, and sometimes I see kids who are nonverbal. So for that questionnaire, I do sometimes have families modify, but if we want to actually track things appropriately, we can't be like willy-nilly making modifications, you know. So that would be my one idea, is at least for the Vineland, if you can separate out that what it's trying to measure from your child's actual cognitive ability, if that might make it a little bit easier for you to complete as an idea.
Just to add on to that, your question is a really nice job of getting to one of the hearts of the idea of testing in general. It's amplified when you have a sensory difference like not being able to see, right? If I'm trying to learn quickly about your child, I can ask you a lot of questions, and I can know very specific things about your child. But I can't, it's harder for me then to think
Hello. Okay. I'm a big fan of more information. So in a clinical sense, even if you mark that item as a 0, if you put like a little star and say, due to vision, or I really think that they have this skill as a clinician, I think that's really helpful to have that information and that input. So I love getting forms back that have all these like highlights or like kind of little notes attached to them, because I think it provides context to these kind of hard questions. And two, when I'm interpreting these clinical results, so again, kind of like the clinical utility, then I can say, you know, some items may be underestimates of true ability due to vision, but again, captures that performance of that child in that moment.
So, follow-up question then. Because I have been answering based on what I think they can do cognitively, not visually. So if the next time I do it then, I answer based on a vision, there's going to be a huge change. So is there a way for the folks who are interpreting that data then to put a little asterisk and be like, well, mom actually did it right this time, so that's why there's a big change?
The first thing I would do is talk to the person who's giving it to you, because I don't want to like speak. I don't think we should speak for them, because like they have the context of how they're thinking about it. But yeah, just have that conversation, right? Because depending on the situation, if it was clinically, I'd probably say keep answering it the way you were answering it, because then I know how it was for you. But if it's for a study and that's going to change your data significantly, they may want to think again without knowing the context of what they're doing.
It's being recorded. The only way I can get your.
Oh, sorry.
Sorry.
That's okay. But just given the different contexts, I would start there just to let them know. And all these things, to me, it's about being as straightforward as possible, because I want the real information irregardless. So I appreciate your willingness to be honest about that, because I'd probably go, oh boy, I probably was doing that wrong. I'll change it, and maybe wouldn't tell people. But I think that's what's going to give us the best information, irregardless of what it is, because we want it to be real.
To kind of piggyback off of that a little bit, do you think it would be better to have like both parents fill it out? Because I know that like it's about perspective sometimes, and I know like my husband and I look at things very differently, and I don't know. I think, wouldn't it be better to have like the dad fill it out, the mom fill it out, and then kind of compare to get like a better, accurate?
So great question. So, and I'd love to hear what others think. So in my practice, I offer all the opportunities. So I ask if mom and dad are with me. I say, do you want to fill out the same form, or would you like to fill out separate forms? So sometimes I think when mom and dad fill out the same form, what I imagine happens is they come to kind of the middle if there's a discrepancy. So that's kind of the form that I have. Or I do let parents fill out the same one, and then it's just really important to track that over time. Mm-hmm.
Yeah, I do the same thing. I think I have it as a conversation, because one, you guys have filled these forms out. It's not like they take 5 minutes, right? Or they take a while. So, and sometimes it depends. I think in many cases your impressions are closer than you think they are. Maybe not yours. I don't know. But so I think if they're likely to be the same, I'd say you may want to just do it yourself. Sometimes it's a good exercise to kind of see where you guys both are. But I think if you're pretty certain, as it sounds like you're saying, that like your impression and dad's impression are significantly different, then it may be good to have that data and to see those differences, because those things can often be real. People behave differently in different contexts. People do different things in different contexts. But also people interpret different things in different contexts. I've seen kids do a lot of behaviors, that maybe most people don't see on a day-to-day basis. So my threshold for a problem behavior is probably higher than many other people's. So I'm like, yeah, they'll be fine, it'll be good. And so yeah, to me, the data is always useful, but we also don't want to overburden you guys with too much work, right? We want to make sure that what we have is being really as helpful as possible. While all of testing is based on the idea of trying to get as much information as you can with the least amount of work that you can, believe it or not. but it's just, it's hard to get a lot of this information. But that's a great question, I think one parents often have.
So I'm a grandparent of two grandchildren with CLN2, and just had a couple questions. One of the things I saw up there, you had constipation, which I understand, lends to irritability, but also dental pain. One granddaughter, she's 20 months old, and we think it's teething, but I saw you had dental pain up there, so I wonder if you can expand a little bit upon that. And the other question I had is, same thing with our one granddaughter, with the behavior part, like every time we put her into the car seat, she is just going crazy. She does not want to do it. We don't know what it's from. If you've encountered anything, as far as that with other patients, and same thing with repetitive behavior, like repeating the same word, or one 5-year-old repeats the same word over and over. So if you had anything on that, would be helpful.
Sure. I would say, so pain and uncomfortable sensory experiences, just generally, especially if kids or adults have communication difficulties or at that phase of the disease. One communicates with the tools that one has to communicate, and especially with a condition where executive function and impulsivity can play a big role, tantruming, aggression, self-injury are all things that can be a way of communicating discomfort. In Batten disease and well outside of Batten disease, kids with significant neurological conditions or neurodevelopmental disorders, constipation, I can't even tell you the number of things, like behavioral issues I've seen people come in with. Some colleagues did a study in an unrelated condition looking at, in an inpatient population that was at high risk for having trouble with urinary issues. And they were doing bladder scans and found that the aggression perfectly matched the volume of urine on the bladder scan. And so it would go up when the kid had to pee and couldn't, and then once they were catheterized or able to go to the bathroom, their behaviors went way down. So just so many of these, kind of core medical bodily needs can be real triggers. And so where that becomes helpful is, one, especially if you see a change in somebody's behaviors or some unexpected jump in some kind of symptom, somebody's being aggressive when they weren't typically, or we'd had self-injury under good control for a few years and it came back, those kinds of things. The first thing to do is look for these fairly treatable underlying medical comorbidities. They are things that we are relative to other diseases and other components of Batten disease. We have decent treatments for them. So those, I think, are always both low-hanging fruit and also things that can play much more of a role in behavioral symptoms than we appreciate. I hope that answers the first part of your question. In terms of sensory sensitivities, that's a tough one. We don't have great medical treatments for sensory sensitivities. I love working with occupational therapists who can do a really in-depth analysis of trying to figure out what the actual trigger of the sensitivity is. There are some kids who love deep pressure, right, and really struggle if they don't have that kind of pressure or restraint. Some kids can't stand it. Some, it's a particular part of their body or the texture of the strap, or, the list is endless. So there's lots of things to look into there. A good OT would probably be a good starting place. And the third part was about repetitive behaviors, right? I think it depends. Some repetitive behaviors, there's a lot of different things to focus on, right? And we can't treat everything. So it partly depends on whether it reaches a threshold for the child themselves and for everybody at home and in the environment. Is it something that we have to treat? Repeating a word over and over can be unpleasant, annoying, unusual, but it may not be the kind of thing where we're thinking, oh, should we start them on a medication for that? Some behavioral interventions or all kinds of things can contribute to that. Language-based symptoms, their underlying cognitive level. So all of those things need to be taken into account. Some repetitive behaviors or rigidities for kids with or young adults with Batten disease can cause real problems, safety issues, it can be really upsetting symptoms. And those, some more intensive behavioral type therapy can work wonders along with certain medications. I saw you grab the mic. I didn't know if you. No. Oh.
So, well, a lot of times for both. So, I love that question because one of the challenges is when people have a more limited repertoire of behaviors, fewer things they do in general. It's tricky because there's less differentiation of what we can kind of read from that, right? If someone's saying the same word over and over again, it could be for a myriad of reasons, right? It could be, I like the way that word sounds, and I'm bored, so I'm going to keep doing it. It could be, I know that when I say words when I hurt, and so I'm saying this word because I hurt. And so Aaron did a nice job of thinking about the context, that A and that ABC, what's happening before, what we call setting events, what's the situation? And if everything's kind of the same and they're just kind of doing it because nothing else is happening, it may be just something they're doing to entertain themselves. It may be something that they're doing because they hurt. And so it's tricky because we have to think about that. And that's where sometimes working with, whether it's occupational therapists, whether it's behavior analysts, whether it's people who can help us all think through what may be happening and build hypotheses. I think of it almost like being kind of a single subject research designer. There's kinds of research where you have one person, you kind of change the situation, and you build a hypothesis, say, well, I think this is what could be happening. So if I think it's because they're hungry and they're really asking for food, they may be saying Dory, 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 but they mean goldfish crackers. So if I give them goldfish crackers, I would expect they would stop saying Dory, Dory, Dory. And so when they start doing it, I give them goldfish crackers, and I see what happens. And if they stop, they go, okay, now I've got it. Dory means goldfish crackers. But if they just keep, then they go, oh, yum, 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 and they go, Dory, Dory, Dory. Okay, well, maybe that wasn't it. So a lot of this is kind of trying to have a hypothesis and see what makes it happen more, what makes it happen less, and then think of the whys, because we have to infer them, right? If they can't tell us, oh gosh, I haven't pooped in 4 days and I'm really starting to feel it. If they can't tell us that, we have to infer it and do our best with that. And then also for the car seat, whenever there's something that you don't love to do, but you have to, getting used to it in small doses. A lot of times what happens when you don't like something is we try to avoid it until you can't avoid it, and then all of a sudden we got to do it. I don't want to wear shoes. Okay, don't wear shoes ever, but oh gosh, now we have to get to school, and so we have to wear shoes. What are we going to do? But instead, if we practice it in small doses, and we think of what would we like you to be doing instead of flailing your arms, we want you to be sitting there. Well, sitting there is also boring. It may be uncomfortable. You may not like the way things feel. There may be sensory differences there. But also, it's boring to sit in a car. And so that may be a time where, you have an activity that you don't allow other times that you have just during this time. So now instead of focusing on how much the shoulder straps are digging into you, you go, oh, wow, I get to watch Dory, because apparently this kid loves Dory. So now I have something that I only get at that time. And instead of and now those other things I didn't love are maybe less of an issue. Now it's not, maybe that works for 5 seconds, it doesn't work. We're trying stuff. But the best predictor of what's going to happen next time is what happened last time. And if we start to change, instead of screaming and crying and screaming and crying, instead for one time we got to just kind of watch it. If we can make that twice, 3 times, we're kind of moving in the right direction. And Annika's walking up, so I'm guessing we're running low on time.
Yeah, I would love this session to go on and on. I think, before I close out, I think I'm going to indulge as a moderator that just hearing you all speak about that and some of these questions, I think next year for this panel, we could even have a speech and language pathologist who works with augmentative and alternative communication, because this is something that we haven't really touched on, but giving the children the tools to communicate in non-verbal ways and alternative communicative ways. And there is some literature out there, and this is sort of a growing field in this, at least in CLN2 and CLN3, we actually have some early research that's being done on the ways of speech and language and communication in those forms. But yeah, I think this is like, it all ties in so intimately, the behaviours and that frustration of communicating and not being able to, express your needs and wants. But yeah, thank you guys, you are the dream team. We're so grateful for you today. I'm going to close it now because I have to whisk them away now to a Centres of Excellence meeting. And they have other assessments ongoing as well. If you haven't gone to the nationwide team to have an assessment, if you have your children here with you, please do consider it. Sorry if you get floodgates now. But thank you all, and thank you, please join me in thanking the speakers.